sorry to interrupt you. Just put the presentation mode. We can see 2 slides.
Actually, is in presentation mode.
Let's see.
Let's see if I can avoid that. Not sure I can actually.
At the top. Yeah, let's see.
Yeah. The issue is that I have 2 screens. Let me try this way, maybe. Is it better now or not?
Not. Let's see. Not yet. Showing it.
The issue is that I have 2 screens.
Okay, so try to share and hit just share a PowerPoint.
Okay. Let me.
Not the screen.
Yeah.
Let's see.
Better.
Yes, right now we can see just the slides. Just put the no. You know, at the top, can you see it? Yeah, okay.
So
try once again.
So I'm sharing the PowerPoint.
Yes.
Right.
And then at the bottom, hit that presentation mode.
Yeah.
Yes, this button.
Do you see it? No.
Yeah, it's not working for some reason. That's interesting. Yeah, it should be all. That's interesting.
Okay, let's try again. I'm sorry for that. Usually,
No, don't worry. And maybe if it's not working, try to share your desktop.
Oh, maybe, you know what? Let me try this. Try to share my second screen.
Oh, that's maybe. Yeah, perfect. That's working.
That works?
Yeah, it's working.
Okay, so let's do that. All right. Okay, sorry for that again. So, this presentation is about, in general, the evolving landscape in the management of men with advanced prostate cancer, so covering different situations. I will try to avoid repetition from the previous presentation, so maybe I will skip a couple of slides that have been showed already. Those are my disclosures. And in just one slide, I like to remind you the major progresses we've made in this disease in the last basically decade or so, or 13 years. And you will see in blue the drugs which were available 10 years ago and which had already shown efficacy in the disease, including, of course, androgen deprivation therapy, docetaxel, and zoledronic acid. Zoledronic acid showing a reduction in the bone morbidity, and docetaxel showing overall survival improvement, as already stated. And now you will see in red all the new drugs that came in the last decade. So you see it's full of red on my slide, which is good news for patients. Starting from the right-hand side, the extreme right, when patients have exhausted many treatments, abiraterone and enzalutamide, cabazitaxel, radium, lutetium, PSMA, olaparib, have shown overall survival in the space. And then you will see that many of these agents have moved to the left-hand side, showing even greater improvement for the patients. And the map, plus or minus replacing zoledronic acid, of course, whenever available. So this is all nice. But now, assuming that we have all these treatments available, and of course, I know that it's not necessarily the case everywhere, including in Vietnam, but what is the best strategy how to use these agents? And I think we can discuss 4 different strategies. The first strategy is earlier treatment. Second strategy is sequence the treatment one after the other one. Third strategy, combine to try to circumvent resistance. Fourth strategy, personalize the treatment and give the gentleman one while the other gentleman will get another treatment. So let me try to review where we currently stand with these four strategies. And let me start with earlier treatment. And start with localized disease. Men with high-risk localized disease who are typically treated, I guess, with radiation therapy and androgen deprivation therapy. And this 1 or 2 years ago now, maybe one of the greatest improvement with systemic treatment or with treatment in general for men with prostate cancer that we've seen in the last 2 decades. And this is thanks to abiraterone in the Stampede localized trial, where you can see that adding abiraterone foods on top of ADT tremendously in survival, and of course metastasis-free survival. We have 7% reduction in the risk of in vivo. If you look at the curve, for example, pick up the one to the left-hand side, they're pretty much the same. But if you look at the curves, you will see that almost no more men with localized disease will die from their prostate cancer in the last 5 to 10 years. The few death events are probably due to other causes, which I think is a very important achievement that was obtained. And I hope that we will be able to use that place. Now, moving a bit later, let's say that the patient has developed a PSA relapse. I think I hear a background noise, so please make sure that your mics are on mute to avoid this background noise again. Thank you. So say that the patient has developed a PSA relapse after local treatment. He started on androgen deprivation therapy because this is a bad biochemical relapse with a rapidly rising PSA or an aggressive cancer, a high Gleason score. Typically it works, but with time, the PSA starts rising again. And this is what we call non-castration-resistant prostate cancer. In this particular space, 3 randomized trials show that overall survival is also clearly improved with early intervention using one of the AR pathway inhibitors, the one you like, of course, Spartan with apalutamide, enzalutamide with Prosper, and darolutamide with Aramis. So again, clear benefit coming together with metastasis-free survival improvement. Still moving to the right, now patients with metastatic disease. The previous speaker explained the benefit that we see with docetaxel in this space. But actually, when you look at the long-term efficacy assessments that were performed in Chartered and Stampede docetaxel, the effect on overall survival was actually lower as compared to originally stated, with only a 27% improvement in the risk of death in Chartered, as opposed to approximately 40% when originally published. And for Stampede, only 19% reduction in the risk of death, again, lower than initially reported. And you see this banana curve, the banana shape of the curves. The 2 curves tend to merge with time, perhaps because we're using the docetaxel for just 4 or 5 months. We cannot do longer than that. And with time, the 2 curves tend to merge. So the Taxol improves overall survival, it's true, but it's far from being perfect. We need better treatments. And actually, abiraterone and other AR pathway inhibitors can probably provide better outcomes for these patients with metastatic sensitivity. Later in the STAMPEDE abiraterone data, clearly showing overall survival improvement with 38% reduction in the risk of death. And you see that the curves tend to diverge more and more with time. We don't see again this emerging phenomenon that we just saw with docetaxel. Metal confirmed with average that to my anatomy, you just later. And now, because I is in a situation money is very important. This is true, unfortunately, everywhere on the planet. But I mentions also that insurance cover everything. So I think the ADC consensus data are a sheet for reference, specifically on countries with limited resources. Was what do you do for your patients with metastatic castration-sensitive disease if you are in a country with limited resources, or if your patient is not fully covered by insurances, when you start androgen deprivation therapy? And you will see that the experts, again, coming from countries with limited resources, were split between bilateral orchiectomy or LHRH agonist to be used for androgen deprivation therapy. So again, both can be used and both are recommended as the first method of achieving castration. A second question was asked also at APCC limited resource countries, which was, what do you do for your patients with high volume man? And you will see that, again, this was split between experts. Half of them recommended ADT alone, and half of them recommended ADT plus docetaxel. Abiraterone was not recommended at this time, but this was actually this meeting was done mostly 2 years ago, before abiraterone became a generic drug in most countries. And it will be, I think, interesting to see now that abiraterone is generic, whether abiraterone can actually be used more often for these men. And you see that also nobody voted for the option 5, which is ADT plus docetaxel plus abiraterone. But again, the question was asked before the data from PEACE-1 and Erasmus were reported. So it will be interesting to see whether all our colleagues from limited resource countries will now more and more use a triplet treatment. A third question was asked for men with low volume, and you will see that for the systemic treatment choice, so not speaking about radiation, ADT alone or ADT plus docetaxel were again the two mostly recommended options. Again, abiraterone was mostly not accessible with no or limited generic options for most of these countries when the question was asked. Now, regarding the use of radiation therapy for these men with low volume disease living in countries with limited availability for radiation units, actually the jury was split again. Half of the jury voting for yes, I would propose radiation therapy for these patients, while the other half would say, well, no, I will reserve radiation therapy resources for other cancer types when this may be even more important, Hodgkin disease, Hodgkin lymphoma, or other lymphomas, or other localized disease situations where radiation is maybe more important. So you see, the jury was well split. Okay, coming back to the science now, the question for these men with metastatic castration-sensitive disease is whether we should combine all the treatment up front, or at least more treatment up front, abiraterone and docetaxel. And actually, we do have data now since about a year now, or a year and a half. Again, this is piece one, asking whether we should intensify men with ADT docetaxel and abiraterone. We have the answer. I'll show that to you in a second. And the second question, piece one is asking, is whether we should keep using radiation therapy in these men who have systemic treatment intensification. We don't have the answer yet, but this should be ready for readout probably this year, hopefully before the summer. But let me review first the data about systemic treatment with a triplet. As shown in the previous talk, this one is a positive phase 3 trial. We see both radiographic progression-free survival improvement, 2 years versus 4.5 years. So we're providing 2.5 additional years of good life to all our patients with a triplet combination versus a doublet. And overall survival is also improved, favoring the triplet, even if this was achieved in a situation where more than 80% of men in the control arm had access to abiraterone or enzalutamide when they developed MCRPC. So in other words, in piece one, we clearly compared early intensification versus sequential treatments with abiraterone and enzalutamide being used later on. And you see that the answer is very clear. Early intensification is better as compared to sequential use of these treatments. If I try to put this into context now, this is what we've done in just a decade. A decade ago, we were using ADT alone for these men, and I'm showing here, for example, for the sake of comparison, men with de novo and high volume disease. These men had less than 3 years of median overall survival. All control arms showing of all phase 3 trials showing the same data, less than 3 years of survival. Docetaxel improved that to 43 months of survival. Abiraterone improved overall survival to, say, 53 months. And now, with free drugs, we see these men living more than 5 years. So in less than a decade, we've moved away from less than 3 years of survival to more than 5 years of survival for these men with the worst outcomes against de novo and high volume, which I think is remarkable. And again, this is achieved with mostly now available drugs and cheaper drugs, ADT, docetaxel, and abiraterone. This is consistent now with our data. We now see 3 phase 3 trials pointing to the same direction. This one, which I just showed you, Arasense, and even Enzamet also has a subgroup of triplet treatment. And you see that in all these 3 phase 3 trials, overall survival is significantly improved, favoring triplet therapy as compared to doublet therapy. I think the standard of care this year, if we have access, of course, to this treatment, for men with de novo and high volume, if they're fit to receive the docetaxel chemotherapy, There should be a triplet treatment, of course, the one you like or the one that's available. For men who are unfit for the start cell or who don't want chemotherapy, ADT plus a second generation hormonal agent should be the standard of care. For men with low volume disease, I guess we should use ADT, the second generation hormonal agent, and radiation therapy based on the STAMPEDE data. We should see more data about combining radiation therapy with second generation hormonal agents soon in piece 1, as I said. Having said that, the triplet data, the triplet treatment should probably be discussed also on a one-by-one basis in men with low volume disease. And I'm saying that because the Erasmus data that you were just showed at ASCO-GU a month ago actually support efficacy for triplet systemic data even in men with low-risk disease. More data is also to come from piece 1, hopefully this year. Now, for men who have a relapse after local treatments and who have not seen hormonal therapy, so again, methyprenous metastatic hormonal sensitive disease, it's hard to make a strong recommendation, to be honest, because these men were very rare in all phase 3 trials that were reported in the last decade. Probably the most meaningful data come from the combination of ADT and a second generation hormonal agent. But again, we should be cautious because we don't have so many data for these men, and specifically for those of them who are at risk for cardiovascular disease, we should measure and be very balanced with other decisions. And I, of course, very well recognize that some patients are just too frail or very elderly, and it's hard to use intensification treatment for these men. So probably ADT alone remains a reasonable standard of care by default for these men. Having said that, we need more data, more treatments, because this remains a lethal disease. And for example, amongst the Peace Consortium in Europe, we are currently developing the Peace 6 program, which is a platform for phase 3 trials. And we are actually asking and trying to answer different questions. For example, for men with oligometastatic disease, we are randomizing the role of stereotactic radiation therapy directed to metastasis. This trial is enrolling rapidly patients as I'm speaking. A second phase 3 trial, which is called Peace Vulnerable, is randomizing the role of darolutamide for men who are frail. We are just about to start, hopefully this year, 2 phase 3 trials for good responders and poor responders based on 6-month PSA values, men who are on systemic treatments, and with an injectable PSA will go for de-escalation randomly, while patients who are poor responders will be randomized to receive even further intensification using lutetium PSMA on top of their ongoing systemic treatments. And these 2 trials should again be out of ground hopefully this year. Okay, so you see, so I took my time on the earlier treatment strategy because obviously this is a win in the last years. So I think this should be more and more what we should use. But let me review briefly what we have in terms of sequential treatments. First question is whether we should keep using the old generation hormonal manipulation, enzalutamide, dexamethasone, estrogens. All these treatments are cheap, but unfortunately they're not very active. And as you can see, in randomized trials comparing old generation versus new generation, the new generation drugs actually win. So, of course, if available, I think we should go for a new generation drug such as abiraterone or enzalutamide as soon as possible for men with mCRPC, if not used earlier. Now we see many more patients progressing after either abiraterone or enzalutamide. And the question is what's next, of course? What food should we use? And this slide is showing you the bad news. And the bad news is that these agents actually have quite strong cross-resistance between each other. So in other words, if you're using abiraterone and you go for enzalutamide, enzalutamide will work in only 25% of these men. And if you do the reverse sequence, enzalutamide first and then abiraterone, it's even worse. Only 5% of men will benefit. So we should prevent us from using this sequence. It just doesn't work. Now, this slide is showing you the good news. And the good news is that taxane remain mostly active in men failing abiraterone or enzalutamide. This data is one of the biggest we have as I'm speaking. It comes from the Q302 trial. It's showing that most men who have exhausted abiraterone still derive benefit from the Taxane chemotherapy with approximately a 50% response rate and a time to progression of approximately 8 months. So not that different as compared to what we see in our routine practice with the Taxane chemotherapy in men who have not seen abiraterone, which I think is very reassuring to all the patients. Also, we have cabazitaxel data in men who have exhausted these drugs. And CARD was a very pragmatic phase 3 trial which focused on men who have received already one taxane and one AR pathway inhibitor, whatever the sequence, one before the other one. And the question was really, should we go for second taxane with cabazitaxel, or should we go for the second AR pathway inhibitor, abiraterone or enzalutamide, depending on what the patient had received in the first place? And as you can see, the answer is very clear. The second taxane is the way forward. Cabazitaxel clearly improves not only regarding progression-free survival, but also overall survival with almost a 3-month difference in medians and a 36% reduction in the risk of death. Don't pay too much attention about which comparator was used. Actually, cabazitaxel won against abiraterone or enzalutamide. Now, coming back to countries with limited resources, we have actually APCC consensus voting about what should be used in terms of chemotherapy doses if a patient has an East Asian ethnicity. So if you're using a taxane, how should you initiate the treatment? And you can see that the jury was split into almost 3/3, with a big 1/3 saying, I will start with standard doses, 75 milligrams per square meter, and I will dose reduce if my patient does not tolerate that. The second third, or fourth actually, will go for a reduced dose, 60 milligrams per square meter, and then I will keep reducing my doses. And the last third would start with reduced dose, but then escalate dose in the absence of relevant side effects. So you see 3 different strategies, and the jury was out to provide a clear guidance. I think these 3 strategies are very meaningful. I tend to dose reduce my docetaxel treatment when I'm facing a man with East Asian ethnicity, but you probably know this much better than me, and I will be too curious to see what your practice is.
Và như vậy thì chúng ta thấy rằng là cái việc giảm
Now,
liều
second
của
question, which was
docetaxel
used
ở nhóm bệnh nhân châu Á,
at
Đông Nam Á là
PCC,
khá là thường gặp
is
ở vấn đề
about
và tôi và những khi mà điều
efficacy
trị cho các bệnh nhân
in
có
patients
vùng và Đông Nam
with
Á, tôi biết
other ethnicities than a Caucasian,
xu hướng là giảm liều cho người bệnh.
which was the major
Và một câu hỏi tiếp theo nữa có thể ngoại
ethnicity
suy
enrolled
được
in
cái
phase 3
kết
trials.
quả của các nghiên cứu
So
dành
the
cho nhóm bệnh nhân
question
châu Âu
was,
vào
can we
cái kết quả điều
extrapolate
trị
the
trên châu Á
data
hay
from
không?
phase 3 trials to other ethnicities for efficacy? And mostly the jury
Không
said
chỉ ở
yes.
châu Á mà kể cả những bệnh nhân thuộc của chủng tộc
66%
khác
of
thì chúng ta
the
thấy rằng là với câu
overall
trả lời là
jury
có thì
members.
66%
But as you
các
can
chuyên
see
gia
here
đồng ý
now,
là có thể áp dụng được.
if you're asking the same question about toxicity,
Với câu hỏi tiếp theo
it's
đó
the
là có thể
exact
ngoại suy cái nguy cơ về độc
opposite
tính ở
answer
những nhóm
that
bệnh
the
nhân
jury is
được sử dụng trong
providing.
nghiên cứu của đại đa
It's a
số là những
clear
nhóm bệnh nhân châu
no
Âu
answer.
vào những cái chủng tộc
We
khác được hay không.
cannot extrapolate the data from phase 3
cái này thì hơi ngược
trials
một chút.
to
73%
our practice,
các chuyên gia lại
especially
không
if
đồng thuận
patients
và người ta
have
nghĩ rằng là
other
cái sự độc
ethnicities.
tính khác nhau
So in
ở
other
giữa
words,
các cái
we should be very
các cái
cautious
chủng tộc khác
in
nhau.
terms of
Chỉ
toxicity.
có
We see
27%
more
là đồng ý là có thể
toxicity
ngoại suy
than what is
từ những kết quả
reported
của
in
nghiên cứu
phase 3
sang
trials.
cái nhóm bệnh nhân châu Á mà thôi.
Let's move now to combination treatments.
Với
And here,
một cái chiến
I
lược điều trị
think
khác
we
thì
don't
nhóm
have
của
so many
CIDC đó là
data
phối hợp các
in
phương pháp điều trị với nhau.
MCRPC. Actually, we have one trial which I
Chúng ta thấy
think
rằng là
is
khi phối hợp
important
đầu tiên là
to shed
Edo
some
phối
light.
hợp với cả radium
And it's a
223 thì
combination
giúp
of
làm giảm cái về
abiraterone
cái
and
nguy cơ
radium
và bị
223.
vết xương hoặc là cái biến cố về xương.
Usually we are happy when we see Kaplan-Meier curves separating like this, blue curve and red curve. But this one actually is not a good news at all, because the control arm is the red curve, and the blue arm is that of the experimental treatment combining abiraterone and radium. And as you can see, in this trial, there was a clear increase in fracture incidence, discovering the radium arm. So we should not combine abiraterone and radium because clearly there is excess in fractures. So why is that? Probably because most patients in this trial did not receive zolinic acid or denosumab to prevent the event of fractures. And actually, a second trial, which is still undergoing, just completing its accrual right now, Peace 3, is asking the same question with enzalutamide as a control arm and enzalutamide and radium as the experimental arm. But because the trial had just started enrolling patients when the first trial read out, an amendment was proposed to make zolinic acid or denosumab mandatory for the next to come patients. And this is the data now. And I think this is very important for our crisis right now. You will see in blue and in green the incidence of fractures for men treated with enzalutamide or enzalutamide and radium without a bone protecting agent. And it's really bad. At 2 years, approximately half patients receiving enzalutamide and radium have developed a fracture, and one out of 4 of the patients receiving enzalutamide alone also has developed a fracture. That's really bad. Now you will see at the bottom of this picture in red and in black the same treatments, enzalutamide or enzalutamide plus radium, but this time in a context where the patient is receiving zolinic acid or denosumab. And you see that it works. Clearly, the incidence of fracture is almost zero. So I think this is a very important message to the practice right now. In men with MCRPC receiving enzalutamide or abiraterone, of course, we should use a bone protecting agent. The one that's available is denosumab or zolinic acid. I think it's very important if
cái
we
thuốc giúp
want to
làm cải
prevent
thiện rõ rệt cái
the
nguy
bone
cơ về những
morbidity
chứng gãy
for
xương
our patients,
cho người
I
bệnh
showed you here the
cái đường
fracture,
tuyến
which
có di
of
căn
course
xương
are
hay
very
loạn tráng
clinically
bên ngoài.
meaningful. But I want also to show you spinal cord compression, which is of course horrible to our patients. We still see approximately a 10% incidence of spinal cord compression in randomized trials with these agents.
Chúng ta thấy rằng đây là cái
If
tỷ
you're
lệ
using
mà
zolinic
bệnh nhân
acid
sẽ
or
xuất hiện cái biến
denosumab,
chứng chèn ép
that
những bệnh
incidence
nhân
will
mà
go down to
ung thư
3 or
tuyến di căn xương đã
4%,
được dùng
which
thuốc
of
bảo vệ
course
xương rồi.
is not the
Những bệnh
same.
nhân không được dùng gì cả thì nguy cơ này là 8%.
All right, let me finish that
Zolinic
talk
acid thì
with
nguy
a
cơ nó
fourth
giảm xuống là
option,
nửa là
which is
4%. Và
personalized
đến
for
xuống
new
2% thôi.
treatments for the
Và cái việc cá
patients.
thể hóa điều
Let's
trị
dream a bit.
cũng là một trong những cái chiến lược trong điều
We
trị
have more and more
ung thư
data
tuyến
coming from the
di căn.
lab indicating how cancer cells can resist
Chúng ta thấy rằng
abiraterone,
là hiện tại thì
enzalutamide,
cái vấn
and
đề sinh học
taxane.
phân tử cũng như là bệnh
And
gen
PET-what
đã giúp cho người ta
androgen
hiểu sâu
receptor
hơn về
pathway
ung thư tuyến giai
remains
đoạn
the
kháng các
main
tinh hoàn
driver of the
và đã
disease.
tìm ra được một số những cái đích mới dành
Basically, it's
cho thuốc
telling
điều
us
trị này. Đầu tiên là
that if we
cái
are
đích
able to
để dành cho
invent
nhóm
a
androgen
new
pathway
abiraterone or super enzalutamide, we may win against this disease even more.
và đây
In
là
some
cái
other men,
nhóm
other
làm
pathways,
giảm cái nguy cơ tiến
kinase,
triển về các
for
thuốc kháng androgen
example, is
sử dụng phối hợp
activated.
thuốc kháng androgen và những thuốc giảm
Repair is
nguy
important,
nguy
and
cơ
there are
kháng
also other
thuốc cải thiện
pathways.
kết quả điều trị hoặc là con
Let
đường
me
beta
try
3
to
hoặc là con
review
đường liên quan đến sự
how
sửa chữa
best
của
we
beta
can perhaps target these other pathways and go for personalized medicine for these men.
và từ đó thì
For
sẽ giúp cá thể
example,
hóa điều trị.
if you're using abiraterone or
Thấy rằng là tỷ
enzalutamide,
lệ mà có đột biến
approximately
androgen
25% of your patients
receptor
will
gặp
develop
khoảng 1/4
AR
các trường hợp
mutations,
nhân
androgen receptor
ung thư tuyến
mutations.
giai đoạn kháng các tinh hoàn như
So
cancer.
in these men, the normal biology, which is what I'm showing here, an androgen binding to wild type AR, will not be
Và khi
anymore the case.
androgen kết hợp vào
For
cái
example,
receptor
with the
của androgen là
L702H
wild type,
mutations,
chúng ta sẽ thấy là
corticosteroids
bên cạnh
are
là corticoid
able to bind to this mutated
kết
version
hợp
of the
vào với
androgen
cả cái
receptor.
bệnh nhân có
Not
đột
anymore
biến
the androgen.
AR ở vị trí
In the
AR4702
L7A
và corticoid được
mutation,
sử dụng phối hợp.
progesterone, which is made by males, of course, not only by female, will bind and activate the androgen
Progesterone được sử
receptor.
dụng như bệnh nhân có cái đột
So
biến
in these men, and I'm speaking
AR4882.
about 1/4 of this patient or the patients, you can do whatever you like against androgens, use abiraterone or enzalutamide or other drugs. It will not work. You need to target corticosteroids or progesterones
Và như vậy
or
cái việc sử
other
dụng thuốc kháng
hormones
androgen đơn
that
thuần
can
trong trường
bind
hợp mà có đột
to
biến như
this
này
mutated version.
sẽ không có hiệu quả bởi vì
And this
là
is
nó đã
exactly
có những
what
cái
we've done
yếu tố
recently
kháng những cái
using
receptor
an
kháng ở
agent
đây
called
và chính vì thế chúng ta cần
ODM2A,
phối hợp
which
thuốc ngay từ
prevents
đầu.
the making of all steroid hormones, including corticosteroids or progesterone, for example, but
Và
also estrogen.
điều trị phối
And
hợp
you will
những thuốc
see
này
here
với cả
that this is a
những
very
cái
clearly
thuốc ví dụ
active
như là
agent
progesterone
in these
và
patients
corticoid để
with mutations. More than half of them
là
actually
nguy cơ
derive
kháng
benefit,
thuốc
even
chẳng
if
hạn
they
cho nghiên cứu
had already
alpha-2
exhausted everything,
ODM208
abiraterone, enzalutamide, docetaxel, cabazitaxel, amongst other drugs. And further development is currently ongoing with this agent. I mentioned the PI3 kinase pathway. It's activated because of PTEN loss in approximately 1/4 of the patients, and that's typically aggressive cancer. So in these men, we should target theoretically at least both the AR pathway, but also
đặc biệt là
PI3
để giảm
kinase
nguy cơ
pathway.
kháng với cả
This photo in the
thuốc điều
phase
trị
3
thế hệ mới.
trial, it's a positive trial, but actually not
Tôi thấy rằng
very
cái
positive. Probably for two reasons. One is because the biomarker was not assessed the right way using immunohistochemistry, but also because this was a too toxic chronic regimen. And of course, if the patient is suffering from daily toxicity, such as diarrhea every day or rash every day, patient just cannot tolerate, and at the end of the day, you're comparing abiraterone versus abiraterone. not hypotosoptive and aberration versus aberration. This is
This
probably why that trial basically failed, and this is, I think, an important lesson for further developments of the concept. Another very important
đó là những
pathway, if
cái
I
đến rất là quan
can
trọng
call this
cái việc điều trị
a pathway,
ung
is
thư thì
DNA
là
repair.
tác kinh hoàn.
Approximately
Ngoài
10
ra
to
thì chúng ta thấy rằng
20%
là
of men
một trong những con
have
đường
DNA
một trong những cái
repair alterations, including germline
đột biến gen
alterations, mostly BRCA2,
liên quan đến
or
việc sửa
somatic
chữa của
DNA repair
các đoạn
mutations
DNA.
in
Chúng
their
ta thấy rằng là ở đây
cancers
có hai
only,
cái nhóm
or
khác nhau.
again, mostly BRCA2. A previous speaker showed that
nhóm thứ hai là
olaparib improves overall survival in men failing
somatic, tức là
docetaxel
khoảng 10%
chemotherapy
các bệnh
and
nhân MCRPC
abiraterone or
thôi,
enzalutamide.
và những bệnh nhân có bất kỳ
And
cái đột biến
olaparib is
nào ở
actually
trong cái
approved
nhóm
in
đột
many
biến
countries
DNA
already
này, thì
in
cái
this
việc điều trị bằng
indication.
olaparib cũng giúp cải thiện
And
cái
the
sống thêm của bệnh nhân.
current
Chúng ta thấy rằng là trong câu
new
hỏi A
generation of
thì cái việc điều
trials
trị bằng
is
olaparib
testing whether we should
trong bệnh nhân có đột
use
biến
PARP
VRC1, VRC2
inhibitors
hoặc ATM
earlier in the
cải thiện
course of
để
the
sống thêm
disease.
toàn bộ.
And for
Nghiên cứu
example, Triton 3,
Triton
which was
so sánh
just
giữa
shown at
rucaparib,
ASCO
tức là một phương
GU
trị
a
pháp
month
khác
ago, and now
dành cho những bệnh nhân có đột biến
published in the New
VRCA
England
hoặc là
Journal,
ATM.
tested another PARP inhibitor, rucaparib, earlier in the course of a disease in men who have
Và ở đây
exerted
thì rucaparib được so sánh với
abiraterone
một là
or
docetaxel hoặc là
enzalutamide,
những thuốc
but
ức chế
not
androgen thế hệ
chemotherapy.
2 như là abiraterone
And
hoặc là
here I think
enzalutamide
this
dành
was a
cho
very
bệnh nhân
ethical phase 3 trial,
ung thư tuyến kháng tác
selecting
kinh hoàn
only
lý
patients
cancer.
with BRCA or ATM alterations who
Và
are
các bệnh nhân ở
randomized to
nhóm này thì
receive
đều
either
có
rucaparib or the physician
đột biến
choice
của
of
hoặc là BRCA
treatment.
hoặc là ATM, và trong
Docetaxel
cái
could be
gen
an
đột biến
option,
của cái nhóm là
but also
bất đoạn sửa chữa
a second
ADN.
generation
Và
ARPA
các bệnh nhân này đều
inhibitor
được sử
in
dụng
men
một
not
trong những
willing
thuốc
to
kháng
receive
androgen thế hệ
docetaxel
mới với
or
hai
not
chỉ có rồi.
candidate for chemo. Importantly, 75% of patients in the control arm had access to a crossover to rucaparib, which I think again is very
trong nghiên
ethical.
cứu này thì người ta cho phép
And
là
as you
có
can
thể
see
chuyển đổi
very
chéo ở
clearly,
nhóm bệnh nhân
and for the
ở
first
nhóm
time
bệnh nhân điều trị
in
bằng
two
docetaxel hoặc
decades,
là chuyển sang
rucaparib
kháng androgen thế hệ
beats
mới. Nếu
docetaxel.
như tiến triển thì có thể chuyển sang
Again,
sử dụng
docetaxel is
rucaparib.
a big
Thì chúng ta
standard
thấy
of
rằng
care
là
for
thời
2
gian sống thêm
decades.
của các tiến
This is
triển
really the first phase 3
RPFS
trials
một cách rõ rệt
where the docetaxel is actually beaten.
với nhóm
And rucaparib also
rucaparib so
won
với cả
against
docetaxel.
the second generation ARPA inhibitor.
Và cũng
Also, and very importantly, when focusing on
thuốc
genes,
sang
in
cái
the
kháng androgen thế hệ tiếp
BRCA
theo.
subgroup, you can see here that rucaparib is the way forward. RPFS is basically doubled for these men, while for men with ATM alteration, there's no benefit.
Và
Once again, telling us
dừng
that
lại và chúng ta thấy rằng là khi so sánh giữa
PARP
các nhóm
inhibitors
gen khác nhau
should be used
thì
mostly in men
cái
with
sự lợi ích
BRCA
mang đến được
alterations,
chủ yếu
not
là từ cái
necessarily for the other ones. Now, and rapidly, I will cover the ongoing debate as to whether we should use PARP inhibitors in all comers, so in other patients, but in patients with BRCA alterations. And as you can see here on the screen, even magnitude phase 3 trial combining niraparib with abiraterone, clearly the combination is better for men with BRCA alteration, but not for men without BRCA alteration. But two recent trials, PROPEL and TALAPRO-2, supported some efficacy with a PARP inhibitor combined with abiraterone or enzalutamide in patients without BRCA alteration. So the debate is whether we should actually test all the patients before using BRCA PARP inhibitors. So this is PROPEL, for example. And as you can see, for men with BRCA alteration, there is clear benefit again and again and again. But for the first time, PROPEL
có đột biến BRCA thì việc điều trị
please remove
thuốc PARP inhibitor cũng giúp cải thiện thời gian sống, và cái sự cải thiện này nó kéo dài khá là ổn định.
I'm sorry, I'm hearing the Vietnamese translation, so please mute this. Thank you so much. So as you can see, for patients without BRCA alterations, what is called all comers, there was some benefit, but honestly, a much more modest benefit with 24% reduction in the risk of rPFS, and this is not OS at all. And speaking about OS, there is no benefit for these men, while for patients with BRCA alteration, as you can see, there is a tremendous overall survival improvement with a hazard ratio of 0.3. So in other words, 70% reduction in the risk of death.
Thì cách điều trị của olaparib cho nhóm bệnh nhân có BRCA
đột biến
thì cũng cải thiện rõ
rệt
về thời gian sống thai nhi tiến triển với cái effect là 0,29. Các tác dụng phụ chủ yếu của olaparib ở đây chúng ta thấy là một là thiếu máu,
significant anemia, half of the patients, and
phối hợp
pulmonary embolism
và olaparib thì cái tỷ lệ nguy cơ thiếu máu đạt được tỷ lệ thiếu máu là tận những
no benefit in
gần
quality of
50%
life
các bệnh
for
nhân.
these all-comer populations.
Khi mà phân tích về chất lượng cuộc sống thì thấy rằng là ở cả hai nhóm thì chất lượng cuộc sống của duy trì là khá tốt và nhóm điều trị phối hợp với chất lượng cuộc sống có thể ở mức cao hơn. Tương tự như vậy, nghiên cứu Talapro so sánh giữa Tala và Enza so với Talazoparib so với cả Enza hoặc Enza đơn thuần thì cũng mang lại những kết quả về hiệu quả tương tự như là Abin kết hợp với Olaparib kết hợp với Abiraterone, và độc tính về thiếu máu cũng gặp khá là thường xuyên ở cái nhóm điều trị phối hợp này. Như vậy, một câu hỏi đặt ra là những bệnh nhân không có đột biến BRCA thì sao? Vai trò của PAP có hay không? Kết quả của những bệnh nhân mà không có đột biến BRCA và cải thiện khi điều trị bằng olaparib trong những propel có thể là hiệu quả thực sự hay không, hay đó chỉ là một cái thay đổi gọi là tình cờ thôi. Và cái giải thích nào về mặt sinh học cho thấy rằng là việc điều trị olaparib cũng mang lại hiệu quả ở những bệnh nhân mà không có BRCA, không có đột biến BRCA.
BRCA alterations, we need to figure this out. But now the medical question is it good enough for use? My personal answer is honestly no in patients without BRCA alterations, because it's an rPFS benefit only and a modest one, 24% reduction, without quality of life benefit, without pain benefit,
nếu bệnh nhân không có đột biến BRCA thì điều trị bằng olaparib có thực sự mang lại giá trị hay không? Bởi vì như trong nghiên cứu Copen thì nó chỉ cải thiện về rPFS mà không phải là cải thiện về OS, những cái kết quả khác, ví dụ như quality of life hoặc là cải thiện về những cái triệu chứng thì vẫn chưa được đưa ra. Và độc tính thì rõ ràng là chúng ta thấy độc tính về thiếu máu hoặc là những độc tính khác cũng tăng hơn ở nhóm điều trị phối hợp olaparib và abiraterone, và như vậy thì mà không kể là độc tính về mặt kinh tế làm tăng cái chi phí điều trị rất là cao. Như vậy cũng đáng để chúng ta điều trị cho bệnh nhân ở nhóm bệnh nhân này.
When I don't know the BRCA status of my patients, when he's referred from elsewhere, and I don't have the time to assess that because patient is degrading rapidly, I honestly giving it a try to carboplatin, and it actually works.
Chúng tôi ở nhóm bệnh nhân là CAPT thì chúng tôi sẽ thử xét nghiệm đột biến BRCA này và chúng tôi sử dụng olaparib. Nói cái hiệu quả lâm sàng này rất là khó đánh giá bởi vì bệnh nhân vẫn ở thời điểm rất là muộn và đi xuống.
So it's probably a very reasonable options for you guys in Vietnam, I believe. Now, and to complete this talks, PSMA is also a very important target. PSMA is a transmembrane protein, very well and very often expressed in men with advanced disease. And as already alluded to by the previous speaker, we now have a positive phase 3 trial, Vision, clearly showing that lutetium PSMA improves overall survival on top of standard of care in men who have exhausted taxane and abiraterone or enzalutamide, was selected by PSMA PET as having expression of a PSMA protein. You see here on the screen very clear data, 48% reduction in the risk of death pairing the PSMA lutetium arm. So you see, we do have now evidence of biomarker-triggered efficacy in this disease. BRCA2 predicts for PARP inhibitors. MSI high predicts for PD-1 inhibitors. PSMA expression predicts for PSMA mutation. And probably more is to come soon. For example, PSMA loss may predict for AKT inhibitors. AR mutations predicts for ligand inhibitors, and CDK12 double mutations, biallelic mutations, predict probably for PD-1 inhibitors. So in conclusion, as a whole, early treatment is clearly better. So if you can do it, please do. This is true with taxane. It's even more true with AR pathway inhibitors. For example, in men with metastatic castration-sensitive disease, in men with high-risk localized disease, in men with M0 CRPC. Sequential treatment is still routinely used by default, mostly. Bone targeting agents are very important in mCRPC. Please make sure you use them, even if it's simply zonulonic acid, if denosumab is too hard to access. There is a clear cross-resistance between abiraterone and enzalutamide, and this is likely true also with apalutamide and darolutamide. So please use one of these drugs, abiraterone, for example, and when you have exhausted it, choose something else. And the good news is that taxane still remain active after abiraterone and enzalutamide, including docetaxel and cabazitaxel. And finally, biomarker-driven medicine is finally arriving in men with prostate cancer, with clear evidence from PARP inhibitor and honestly carboplatin as well, and PSMA mutation. With that, I thank you very much for your attention. I'm very happy to take questions, if any. Thank you so much. So I cannot hear any speaker, but I'm happy to take questions, if any. Oh, please feel free to comment regarding the Vietnamese treatments, which are available and how you guys use them, of course.
Professor Fizarzi, I think they're just fixing, I think, the interpretation channel.
Oh, sure.
We cannot hear. There is some questions in the question and answer channel.
Oh, okay. Yeah, I see that. I can take those which are
một vài cái thông tin khác nữa về các cái nghiên cứu mà kết hợp mà những cái thuốc mà radium 223 để cho giảm những biến cố trên xương thì cũng được chỉ định để tránh những cái biến cố mang lại cái chất lượng sống cho người bệnh. Thì một vài cái nhóm mà có cũng giống như nội dung mà tiến sĩ Hòa trình bày, ví dụ như là có đột biến BRCA hoặc ATM thì kết hợp với những thuốc ức chế PARP hoặc là kháng nguyên, sử dụng những cái thuốc kháng nguyên màng đặc hiệu với tuyến tiền liệt. Thì sau đây thì đúng quá theo cái lịch trình chúng ta quá 10 phút thì chúng ta sẽ có thời gian thảo luận là 20 phút. Thì chúng tôi xin mời các báo cáo viên sẽ cùng trả lời những câu hỏi của các quý vị đồng nghiệp. Và xin mời các câu hỏi online có thể là chiếu lên trên màn hình, và sau đó thì tại hội trường có những câu hỏi thì sẽ được gửi tới các báo cáo viên. Có rất nhiều câu hỏi.
I'm sorry, I don't know if the question was asked to me, but this was in Vietnamese, and this was not translated to me, so I could not understand. I'm so sorry if the question was to me. Maybe I can take one or two questions from the chat, because some of them are in English. And then if you can please translate in English the questions from the audience, I'd be happy to answer them. So one question was, what duration of therapy is good enough for MCRPC and aberration? My answer would be mostly until progression. Sometimes I tend to use even a longer duration of aberration if the patient is progressing with an indolent progression, then sometimes I carry on with aberration. The second question I read in English is, what is your opinion about steroid switch in MCRPC for a patient on aberration? I think it's probably a very reasonable option if a patient is not progressing rapidly. Approximately 30% of men will benefit from a switch from prednisone to dexamethasone. So if your patient is non-symptomatic, I think it's very reasonable. I'm doing it myself in my practice. Now, if a patient has a symptomatic progression, I tend not to use it because then the chance of success, remains limited, say 30%. So I think it's more reasonable to go for example, taxane. The other questions I see in the chat are in Vietnamese, so I cannot read that. Sorry for that. Feel free to write in English, or if the translator can help me.
There is one question in the chat box, Professor, right now.
Okay. Let me go to there. The one I see are in English, but I think I saw a comment asking me about low-dose abiraterone. I think this is also a very reasonable option. We don't have a phase 3, but we have a randomized phase 2 trial suggesting that 250 milligram of abiraterone with food is similar in terms of pharmacokinetics, efficacy, and safety as compared to the classical dose of 1 gram without food. So when I see a patient coming from a low-income country, I'm actually proposing this gentleman to receive that if he's paying out of a pocket. Again, if I can use 1 gram, I'm using 1 gram because all phase 3 trials will be have been used with this regimen. So I think this is stronger evidence. But of course, if the patients cannot afford paying for 1 gram, I go for 250. Okay, let me go to another question maybe. Between abiraterone and xalutamide, how is the clinical experience of the expert's choice for patients with MCSPC and MCRPC? Well, I tend to favor in most patients abiraterone, but mostly for toxicity reasons and for cost reasons. Honestly, the efficacy appears to be very similar between the agents. We have a randomized trials coming from Canada showing very similar efficacy between the two agents. Abiraterone is honestly usually better tolerated from a cognitive function standpoint. Many elderly patients cannot tolerate the full dose of enzalutamide, to be honest. Hypertension is being seen with both agents. We thought it was only abiraterone 10 years ago, but it appeared that the incidence is very similar with enzalutamide. So I tend mostly to use abiraterone for these reasons, again, taking into consideration the cost which is much lower with enzalutamide. But there are exceptions. Okay, this was the question of the dose. Do I have any other questions? About a case, one patient with MCSPC, high volume, suitable for the indication of ADT combined with abiraterone, but did not have enough money to use for I guess 1 gram. So between the options, use chemotherapy using low dose of ABI. How should I advise you? Right, I think this is very reasonable. It's hard to address your question, for sure, of course. You know what? If it were my patients with high volume disease and is fit for chemotherapy, I would probably go for docetaxel and low dose abiraterone using 250 milligrams. At least this is what I would, recommend to my patient. And then depending on what he can afford, of course, we will discuss. But medically speaking, this is what I would recommend to the gentleman. Let's see. I don't see other questions. Is there another one? Oh, I have a 17-year-old male with prostate cancer. 17, is that true? Is that 70 or 17? 70 or 17?
71, sorry.
Oh, 71, okay. Because I've never seen that. Okay, 71-year-old male, prostate cancer, bilateral pericardial effusion, bilateral pleural effusion, cervical lymph node metastasis by fall of mass. No specific treatment. I ask for your opinion. Again, I mean, this is obviously a high risk, high volume. I would probably go for ADT, docetaxel. Probably I would be prudent if he's sick. Maybe 60 milligram per square meter of docetaxel chemo, at least for the first dose. And I would use also abiraterone. I think that would be reasonable. The creatinine is not crazy high. So I think that would probably be a reasonable treatment. I think we should intensify the treatment